Well, thank you, JW, and the organizing committee of the Stoelting conference. Is actually my first time here, and this hasn't failed to disappoint. So thank you all for having me. I'm going to talk about acute care and wearable technology. After that, excellent start to the morning, talking more about the regulatory aspect of things, and then the nitty-gritties of what goes behind the technology. I'm going to try and talk about the research, or in my words, sort of the lack of research or the need for more research in the area. These are some of my affiliations and relevant disclosures. None of this is a academic conflict of interest on the material I'm going to present to you today. Now, I'm going to start with a very basic slide, and for my colleagues in anesthesia who've sort of seen this data before, this is not new. We do a great job taking care of our patients in the operating room. People do not die in the operating room during elective surgical procedures. That mortality rate is next to negligible. But time and again, data has come up in the post-operative period that really asks us the question of post-operative patient safety. So here, for example, this publication in the Lancet labels post-operative deaths as still the third most common cause of worldwide mortality, not just in the developing world, but in middle and high-income countries as well. So if these are the patients we're taking great care of in the operating room, then what is happening as they're stepping out of the operating room and before they're going home, they're having such a high mortality rate? Well, even though I am an intensivist, I say the problem really lies beyond the ICU. And again, this is just some of the published data. There's tons of published data like this that really shows that, again, for example, most of patients who die in a hospital are never admitted to an ICU at any stage. More than half of all adverse events that happen in hospitalized patients occur on the general care ward. And then when they occur, they're responsible for a large chunk of all of post-operative mortality. So clearly, not the operating room, not the intensive care unit, but outside of the walls of the operating room or the ICU. And here is my favorite analogy to the world we live in. It's the flight data recorder. And I was thinking about this as I boarded my flight to Vegas yesterday. Get on your flight, and the captain or the first officer comes on and says, we're flying a brand new aircraft today. Everything is great, except I don't have a functional flight data recorder. How many of you would deplane? How many of you would deplane? Just Dr. Tremper or a few others? Okay. So the rest of you would stay on an airplane that's brand new, but without a flight data recorder. And I love this because that's exactly what we're doing to the patients on the hospital floor. We are making assumptions for patient safety and saying, okay, it's fine. Our patients on the hospital floor are on the floor because they are okay, so we won't monitor them. And when they crash, it's okay. They come to the ICU. I wake up at 4 o'clock in the morning. I admit them. I order 20,000 tests on them, and that's all good. And I still don't know what happened to them because unlike aviation, we don't want to learn from our mistakes. We don't want to detect pattern changes that led to that catastrophic event that led to that unplanned ICU admission. So I'm glad that all of you do not want flight data recorders on your airplanes. Well, think about it as you're going back home. Code blues do not occur out of the blue. They're named code blues, and they happen. You hear the overhead alarm sound. Data suggests that a lot of these patients actually have at least one abnormal vital sign up to 4 hours before an actual cardiorespiratory arrest event. And data also suggests that as the number of abnormal preceding vital signs increase, so does the outcome after the code blue event worsens. So the common sense solution seems to be early intervention when these abnormal vital signs first start accumulating, because clearly as more abnormal vital signs accumulate before a code blue event, the outcome proportionately worsens. And, I put this in an infographic in critical care a few years ago. Seems to be a very simple solution right here. This is sort of what we're doing, not just in the United States, but all over the world. Patients are intermittently monitored on a general hospital floor. A nurse on the general hospital floor usually takes care of anywhere from 6 to 10 patients. He or she is monitoring these patients maybe once a shift, once in 4 hours, once in 6 hours. Here's a patient who's resting comfortably at 4 o'clock in the morning, but then is having probably some obstructive or desaturation events. Someone comes and checks in on this patient 6 o'clock in the morning, and here's a code blue ready to be called, right? But in the perfect world, this patient would have a wireless wearable that would transmit data in a closed loop environment, and someone would get alerted and would intervene immediately and probably save this from happening. Now, it seems to be really simple. It seems to be a no-brainer. Why don't we just do it on everyone? There is lots and lots of problems, and you know, I'll bring forth those problems as I go on. But I want to also tell you the falling off the monitoring cliff situation, and thoughts here are courtesy my good friend and collaborator, Dr. Turan from the Cleveland Clinic. He and I were talking about this one day, and he said, what is the average surgical time where we provide anesthesia? It's about 130 minutes. We monitor with an NIBP blood pressure every 5 minutes, mostly, right? So we monitor a patient in the operating room when we're standing at the patient's bedside or standing by the anesthesia machine, someone is, 26 times over a period of about 2 hours, right? The same patient then has an average hospital length stay of about 3 days. During that period, we monitor blood pressure every once in 4 hours at best. So we've gone from 26 times in 2 hours while we're actually there to 18 times over 3 days when we're not present at the bedside. And then the same patient just goes home. We say, okay, good luck, you know, monitor yourself, and hopefully you stay at home and you make a peaceful recovery. This is truly, truly not just having a flight data recorder, but maybe having a flight data recorder, taking it off and throwing it away, which really is not doing justice to our patients. Now, we did some initial work, again, with Turan and colleagues, where we put continuous blinded post-operative blood pressure monitoring with a wireless wearable device on a general hospital floor. And we saw that post-operative hypotension was common and undetected. This was in an environment where routinely continuous monitoring is not done. So what we saw, for example, here was that a fifth of our patients had 30 continuous minutes of MAPS less than 65. And again, in the red font, we also saw that spot check, traditional monitoring, missed about half of all episodes of MAPS less than 65 that were detected by continuous monitoring. So keep that thought, keep this slide in your heads, and I'm going to come back to it later on. On the other side is the respiratory side of things on the general hospital floor. I had the pleasure of leading the Prodigy study a few years ago. We put continuous capnography and oximetry on all patients who were receiving parenteral opioids on a general hospital floor. And this was an international study. It was done across 3 continents. There were 1,400 patients in our final cohort. And even though the monitoring itself was tethered, the data was really interesting in that about half of all of our patients had at least one monitor-detected opioid-induced respiratory depression episode that was adjudicated by an independent committee, and we had strict criteria on what we labeled as an OIRD. So clearly, there is a lot of things that are ongoing on the general hospital floor, both with hemodynamics and with respiratory depression, that we don't pick up in the absence of continuous monitoring. Matt Sherpick published this a few years ago, and this is really interesting. So he wanted to examine what vital signs trends on the hospital ward are predictive of poor outcomes, clinically relevant poor events, and respiratory rate appeared to be the one that led this pattern here. And this is an AUC ROC on the other side. So both respiratory rate and heart rate were the 2 vital signs trends that appeared to be most predictive of clinically relevant patient outcomes. This is what is happening with respiratory rate, and I'm sure some of you have probably seen this slide before. So The big yellow dots is our documentation of respiratory rates in the EMR. Usually that number is between 12 and 16, maybe 18 at some places. This is what a continuous monitoring device is picking up. It's picking up a general trend, an upward trend in the respiratory rate. Here is an ICU transfer right here, right? And you can clearly see that there was a problem. We kept on documenting the respiratory rate as normal, but then the patient crashed at some point. So clearly, respiratory rate is an enigma, and we need to work on it. Now, here's some unpublished data. So with some colleagues, I thought through this, and we said, okay, let's see what the evidence has shown us over the years. So we did a systematic review and meta-analysis looking at the role of continuous pulse oximetry and or capnography in combination or by itself on the general hospital floor compared to regular intermittent vital signs monitoring in the prevention of postoperative respiratory failure and the detection of hypoxemia and clinically relevant events like ICU transfer and the use of non-invasive ventilation and mortality and reintubation and so on and so forth. Now, a slightly crowded slide here, but what I want to point out is that the only thing we saw in this systematic review and meta-analysis, which is unpublished as yet, was that the only thing that these devices are doing is detecting a lot of desaturation. So the odds of picking up desaturation was way in the favor of continuous monitoring. Everything else, including ICU transfers, reintubation, and in our analysis, non-invasive ventilation as well, did not make a difference whether you were using continuous capnography, oximetry, or not. Now, the problem, though, is that the studies, the quality of these studies, there's not enough data, there's not enough evidence. And I'll tell you very soon why there's not enough evidence. There's also a wearable or a smart monitoring patch for nearly, like they come in all shapes and sizes. They're available all over the place. I can order them off Amazon, and they are flooding the market. Now, the problem, though, is, and again, in this slide, I'm not trying to advocate for any particular device. The problem, though, is we must put wireless wearables through real-world testing. This is actually at a ACER meeting. ACER is coming up next week, and I'm on the board of directors for ACER, so please come over to Nashville. This is at an ACER meeting where I was at a continuous monitoring workshop. I put some of these devices on myself as I was talking, and I can tell you that my own blood pressure was being read all over the place half an hour later of me waving my hands all around and resting my hands on the table. So clearly, we need to put devices through real-world testing. This is not about putting the device, testing it in a research environment, and saying, oh, look, the data looks great. These are patients who are going to move around, walk the hallways, and their blood pressures and vital signs are going to look, don't look normal at all when these devices are put through that kind of test. Now, the other problem is the validation of these devices. So with Burnsogel and colleagues, we published this editorial in Anesthesiology where we looked at the challenges of automated, continuous, non-invasive ward monitoring. And we sort of said this is a three-step process. When a device, and I've got industry in the room here, I understand, but when we come together, when a device technology comes to me, number one, I ask for validation data. I must know validation data for that sticker, that patch against the gold standard, and I must know the exact tests that were performed statistically to determine the quality of that validation data. Number two, and that's what we lack today, is interventional outcome studies. Few and far between, I would say negligible in the world of continuous monitoring. And number three, the implementation science, which is the real challenge. The hospital nurses at Wake Forest do not like me because I keep talking about continuous monitoring, and it adds a layer or several layers of work for them, at least what they perceive as work. And honestly, if I tell you, most evidence these days is stuck between 1 and 2. We haven't even come at 2 or beyond from 2 to 3 when you talk about the evidence for wireless wearable monitoring on the general hospital floor. So some of you in this room were involved in this survey, and some of you were actually respondents on this survey, so I thank you for this. We did a survey for wireless wearable for anesthesiologists in Western Europe and in the USA, and I won't go through all of the data on the survey, but some of the results were really interesting on what you all think should be done for wireless wearable monitoring. A large chunk of you think that wireless wearables should be put at least on all high-risk patients, although about 25%, I'm happy, 25% think that they should be put on all patients, irrespective of underlying risk. Again, that's up for debate, so we need more risk stratification tools. What kind of wearables would you like to monitor? What things would you like to monitor? Well, looks like oxygen saturation. I think we find it easy to deal with oxygen saturation, heart rate or pulse rate, and then blood pressure and respiratory rate, despite the fact that's such a predictor of poor outcomes. Only about 50% wanted to continuously monitor respiratory rate on the general hospital ward. What sensor would be ideal? Most of us said wrist devices. I think we're very comfortable with wrist devices. Some said adhesive patches, others said finger sensors or rings, and then there was a whole plethora of things like necklaces and videos and belts and so on and so forth. But what are the main implementation challenges? And this is really important because we are here to talk about implementation challenges threefold: return on investment, so the economic part of things, and again, we talked about that a little bit. Connectivity or IT issues, as Anura highlighted, I think we're really struggling with that part. And then we labeled it nurse pushback in the survey. I think it's not just nurse pushback, it's pushback from the providers who have to deal with the consequences of me trying to continuously monitor every patient on the hospital ward. And that are currently that first line of defense is our floor hospital ward nurses. So I'm going to then spend a little bit of time just talking about our experiences at Wake Forest. We have a unique ecosystem in this institution where about 80% of our hospital ward patients are continuously monitored with this completely wireless technology, and I have no affiliations with this technology. It was in place before I came to Wake Forest, in full disclosure. We are continuously monitoring every 15 seconds of EKG, heart rate, oxygen saturation, blood pressure, respiratory rate, skin temperature, patient mobility, and atrial fibrillation as well. This is how our data is currently flowing. About 80% of our hospital wards are hardwired with this monitoring device that goes on the patient. There is an internal patient data server, and then all of the data is being transmitted to the device cloud storage system. Anytime I need the data for research or analytics, I have to request the device company and get the data from them. This is what our monitoring system looks like. So if you walk through our hospital ward, every hospital ward hallway has these large RVDs or video displays where every single patient room has continuous vital signs come up every 15 seconds. Also shows if the patient is in bed, what position the bed in, is the patient rotated one way or the other, or is the patient standing, et cetera, et cetera. And then we have an internal dashboard that I have access to where I can do some basic analytics on how much time patient spent under a certain blood pressure, respiratory rate, other vital signs, and so on and so forth. The vision going forward, at least from my perspective, if I was in charge, I would try and make this a system where the wearable devices, the management server, the EMR, and the analytics is all internal to us, and we don't have to send the data onto the devices, remote cloud, and request data back every time, because that is an additional layer where we lose data and there's missingness and so on and so forth. And the vision also, and we've talked a little bit about this, is that all of these vital signs should then develop themselves into a predictive analytic model that helps us estimate ahead of time what patients are likely to get into trouble. Not just the fact that my patient has a low blood pressure. Well, even though low blood pressure is important, some patients have low blood pressure and they're sitting and watching TV. I want to know what is a pattern of a collection of vital signs that is predictive of a clinically relevant patient event. Now, this is, again, unpublished data. This is just my internal data. And we've seen that we are looking at, for example, hypoxemia here, and I'll show you other examples as well. we are able to see the effect of continuous monitoring and the use of real-time alarms and alerts that are enabled in our system. So our SpO2 alarm is set at 85% for our hospital ward patients. As you all can see here, the x-axis is a threshold SpO2, y-axis is a percentage of patients. Different colored lines are the different cumulative minutes spent under various thresholds. There is a significant amount of hypoxemia here, so significant amounts of time spent between oxygen sats of 85 to 90. But as you drop below 85, because we have real-world alarms enabled and people intervening, there is very little hypoxemia below 85. Similarly, for respiratory rate right here, again, our threshold alarms are set at somewhere between 6 and 8, and it falls off pretty quickly, at least below a respiratory rate of 6, but there's ample number of patients who are sitting between a respiratory rate of 8 and 10. So what are we looking at? Let me just take you back to the postoperative hypotension data that I showed you a little bit ago. This was done at another institution. Lots of postoperative hypotension with a wireless wearable device in an environment where continuous monitoring was not the standard of care. I recently repeated the same experiment at Wake Forest in 15,000 patients, this time in an environment where continuous monitoring is a standard of care and we have alarms and alerts to low blood pressure. This is retrospective data in 15,000 patients. Our postoperative hypotension incidence was way less than the other published study in anesthesiology. So our postoperative hypotension, only about 10% of our patients had MAP less than 70 for 30 cumulative minutes. So even though it's not a head-to-head direct comparison, I will say that this helps me validate that alarms and interventions, and if you implement a continuous monitoring system, there's hopefully less perturbations in vital signs on the general hospital floor. And again, lots of numbers on this slide. We also built some models where we wanted to see, well, if we did not have continuous monitoring and we did have only intermittent monitoring, how much hypotension, hypertension, bradycardia, or tachycardia our patients would face. And the short answer here, without going into the numbers, is that there will be a significant amount of undetected vital signs changes in the absence of continuous monitoring had we not had continuous monitoring. And all of this is available in this just published paper with an editorial written with lots of supplementary tables. So feel free to look at it, and I'm happy to take questions if you end up reading this paper and have questions about it. So as I sort of come to the back end of this presentation, looks like continuous wireless monitoring is an obvious answer, but I say it's not. And it's probably not because there's, like I said, a fourfold challenge: lack of implementation, actually lack of appropriate evidence, lack of implementation, alarm fatigue, huge problem, and then return on investment that we have no answer to as of today. Let's look at the evidence. Frederick Michaud published this nice little table in a review, talks about sort of the published evidence around continuous monitoring on the general hospital floor. There is lots and lots of before and after type study designs. Historical cohort, implement continuous monitoring, and see that it makes a difference in a lot of hard outcomes that I've actually highlighted here. The one with the red arrowhead here is actually from our own institution. Again, a before and after study design that did show that there was a significant decrease in rapid response team events. Now, we are all aware of the problems of before and after study designs. So let me highlight one such study, great study, actually using the same devices that we use at Wake Forest. This comes from a hospital system in the United Kingdom, before and after type study, and they saw a very statistically significant decrease in ICU admissions and rapid response calls after they implemented continuous wireless vital sign monitoring on the general hospital floor. Now, what are we doing? Again, I'm sorry, this is still unpublished, but I'm sharing this with you. we looked at a propensity-matched cohort at Wake Forest. So when we implemented continuous monitoring, a lot of our patients did not have continuous monitoring, so it came on in a stepwise manner. So in nearly 36,000 patients, there were very extensively propensity matched on all of the things that could affect outcomes. We did see that continuous monitoring did lead to very, very favorable impact on the risk of myocardial infarction, risk of ICU admission, and other organ system failure as well. And again, I'm happy to discuss these unpublished data offline. I am excited about this one. This was, I just completed last year, a cluster randomized pragmatic trial where 2 hospital wards at Wake Forest were every 4 weeks alternated between continuous monitoring that was available to providers with alarms on versus continuous monitoring that was blinded and silenced and was recording in the background where providers had to go back to traditional monitoring. And interestingly, the biggest difference we saw was, again, desaturation. So the risk ratios were significant for desaturation, which means that if you had continuous monitoring, you had a significantly less risk of having desaturation events. Blood pressure, again, non-significant differences. Tachycardia, non-significant differences. The composites, and I've not mentioned what the composites are. The composite outcomes are a combination of desaturation, hypotension, and tachycardia. The composites were in favor of continuous monitoring, but again, the composites were driven by oxygen saturation. Importantly, we did troponin surveillance on all of these patients. There were 900 patients randomized in this cohort, daily troponin on all of these patients, because I did want to see that if we're not detecting enough hypotension, is it going to make a difference in myocardial injury and possibly downstream poor outcomes? No difference in myocardial injury whatsoever, because we did not see that there was prolonged sustained hypotension in the absence of continuous monitoring. Again, unpublished, hopefully soon to be published. I'm happy to share that with you. Very quickly, the issue is that there's problems with perceptions around vital signs monitoring on the general hospital floor. This is our internal data that just validates what I've been talking about. When we look at the response to alarms, oxygen saturation is the one alarm that is responded to all the time. In that pie chart, 50% of it is oxygen desaturation. Folks respond to it and correct it. But things like respiratory rate and heart rate, people struggle with what to do with a slightly higher respiratory rate, or what to do with a slightly lower respiratory rate, right? So they will call a code when someone's respiratory rate is 4, but they don't know what to do with a respiratory rate of 8 or a respiratory rate of 18 for that matter, right? So that's a problem. And we did a nursing survey at an institution that exactly showed the same thing. Low respiratory rate was the one thing that nurses were most concerned about, but also didn't know what to do with. So again, a problem, right? So we know it's a problem. We don't know what to do with it. I will also tell you that as we talk about building evidence and improving patient safety with wireless wearable monitoring, we are leaving patients out of this discussion, which is really, really unfair. I gave you the example of the flight data recorder, and I said at least the captain or the first officer came on and told me that the plane did not have a flight data recorder. In our case, we are putting patients in our hospitals after complex surgery. We're leaving them outside the ICU because ICUs don't have enough beds. And then we're not asking them, do they want to be continuously monitored or not? And if they do want to be continuously monitored, what are their perceptions around continuous vital signs monitoring? So think about it. Of all the good things we talk to our patients about, we don't talk to them about patient safety, and we don't talk to them about the fact that we actually take away their iWatches when they come into the hospital. Say, give that to your nurse. Don't wear your wearable. So unfortunate. I wish they'd at least be allowed to wear their digital watches. That will at least save them from something. Finally, it's not all about hypotension and hypoxemia. Our group has looked very carefully at mobility data. With our vital signs monitoring system, we're able to validate whether a patient is supine, semi-recumbent in bed, or is standing by the side of the bed. And also, we've gotten more than 10 million posture readings in our data set that we published validation data on. And very recently, collaborated with Dan Sessler and Alparslan to publish this in JAMA Surgery. Nearly 9,000 patients at Wake Forest with continuous mobility data. And in a retrospective study, and I know you all will say, huge amounts of confounding here, we had a nearly 30% risk reduction in hard outcomes, including mortality, for every 4 minutes per hour of mobility units. So the answer to this is we need a prospective interventional study that someone will fund at some stage. But right now, people will look at this and say, wow, that's a great signal. You publish this in the JAMA Surgery. But clearly, patients who are more likely to have a pneumonia or a DVT or a complication are likely to stay in bed. So what are you telling me, right? Again, all I'm saying is the signal seems really strong. Encourage you to read the paper. So the future, ladies and gentlemen, is pattern detection. This is from our Prodigy data set. In the interest of time, I probably will skip over this today. But the future is that all of our patients should have continuous monitoring that shows patterns of vital signs changes, whether it's oxygen saturation, ventilation, heart rate, and so on and so forth, and correlates it with a clinically relevant event. I also call it the EKG, or the continuous EKG of vital signs on the general hospital floor. This was the Prodigy study. I'd like to acknowledge all of those who participated in it. We built the Prodigy risk prediction score that actually looked at what patients are at the highest risk of opioid-induced respiratory depression on the general hospital floor. Frederick Michard talks about the future as well, and he talks about machine learning and AI being sort of a natural progression to all of this continuous monitoring on the floor, because all of this is, in the end, just a pattern of changes with heart rate, respiratory rate, oxygen saturation, and so on and so forth. So all of the AI enthusiasts in this audience hopefully are encouraged when they see all of this. And you all have seen this as well. You know, there's been a number of editorials written on a hospital system of the future, where patients, either every patient will have continuous wireless wearable technology on them, and then we'll have some sort of a command center that filters out the noise and artifact, and then an AI engine in the back that also incorporates labs and patient values. And then, most importantly, I hope there will be an actual efferent response arm, because that is the one thing we're really lacking and struggling with today. We're okay putting devices on people, but we really don't know how to respond. That efferent arm is missing. And really, I don't need to say it again and again, but Frederick Michard does a great job with this. And I love this infographic. He talks about, what do we really need more reasons for continuous monitoring on hospital wards in the setting of, you know, opioid-induced respiratory depression, nursing shortages, ICU bed shortages, more complicated high-risk surgeries, and increased frailty and the geriatric population landing themselves in the hospital. We really need to do all of this. So my final slide is really looking at next steps. And next steps, I will say in short, I've talked about all of this, including having the right trial design to examine patient-centric outcomes, having a rich repository of vital signs data and doing the analytics on it, looking at alarm fatigue. I didn't have enough time to talk about that, really analysis of alarm fatigue with modeling of alarm thresholds, patient safety guidelines, of hopefully a national patient safety consortium that looks at continuous monitoring in and of itself. And really, the help I'm asking for here is that we, as anesthesiologists and perioperative physicians, really take ownership of the space. We've for long been sort of guilty of saying, well, you know, not really my problem. It is really our problem, one way or the other. So I hope that we're going to take ownership of the space. This is my research team at Wake Forest. It's growing leaps and bounds. I want to thank them. They're more than 30 now in number, and they're doing all of this great work that we do for vital signs monitoring within and outside the ICU. Thank you so much for your very kind listening today.